Greetings, everyone. Happy Monday. Thank you for joining me for Reimagining Education, Conversations on Character and the Common Good. This series is part of the Virtues and Vocations initiative, which seeks to make character, purpose, and meaning central to education and pre-professional and professional education in particular. This initiative is a collaboration between Notre Dame and Duke universities. My name is Suzanne Shanahan, and I direct the Center for Social Concerns at Notre Dame. Before we jump into today's conversation, just two logistical notes. First, as there often are challenges with Zoom, please do know that there are several folks behind the scenes who will swiftly jump in to address any issues should they emerge. Second, we're going to have a conversation for about 40 minutes, at which point we'll turn it open to Q&A. Please pass those questions along through the Q&A mechanism, and they will come directly to me to ask of today's guest. And with that, I'm delighted to introduce Victor Montori on careful and kind care in medicine. Dr. Victor Montori is a professor of medicine at the Mayo Clinic. He is an endocrinologist, health services researcher, and care activist. He is the author of more than 700 peer-reviewed publications and is amongst the most cited researchers in clinical medicine and social science. Dr. Montori is recognized as an expert in evidence-based medicine, shared decision-making, and minimally disruptive medicine. He works in Rochester, Minnesota at Mayo Clinic's KER unit to advance person-centered care for patients with diabetes and other chronic conditions. He is author of the fabulous book, We Revolt, and is leading a movement, a patient revolution for careful and kind care for all. Welcome, Victor.
Thank you very much, Suzanne. Thank you for that wonderful introduction.
It's just delightful to have you here today. And I think what I'm hoping to do in the conversation is get a sense of what brought you to this particular perspective on medicine. If you could give us a little bit of your background and how you came to this particular argument, then I'd love to hear how you think this argument implicates how we educate future doctors, both undergraduates who are interested in pre-health, but then also medical students. And then maybe if you could reflect on these crazy past 2 years as a doctor and as a physician, what that's meant for you and how it is either changed or perhaps reinforced your revolutionary efforts. So.
Wonderful. I look forward to that. I think it will be wonderful 3 hours of conversation.
Great. So maybe you could start with your journey as a physician, what brought you to medicine, and how you started to think about it more recently.
So I'm originally from Peru in South America, and in Peru, you go to medical school directly off high school. And so you have to make this decision to go to medical school when you're 16 years old. So any justification for me going to medical school that sounds very thoughtful or anything, it's an adolescent decision, pretty clear. It's an 8-year journey. And so by the end of the 8 years, you basically have a sense of, you start finding justifications for why you went through that. When I applied for medical training in the United States for residency training in internal medicine, I had perhaps a bit more formed idea of the kind of doctor I wanted to become. I wanted to be a physician for adults, particularly for older adults. But I went to a funny medical school in the sense that the medical school that I attended, Cayetano Heredia, was a fairly young medical school. It was formed in the 60s, and from its inception, it was a very it made a strong effort by location, by curriculum, to situate the training of future doctors in the social and economic context of the patients that we would see. And so I didn't recognize it at the time. In fact, I was the valedictorian for my medical school class, and in the speech that I still have framed in my home back in Peru. My mom had it framed. The speech still says that we wasted a lot of time discussing those things. I didn't, even at the time of graduation, I didn't understand the impact of the exposure over those 8 years to issues of sociology and anthropology and the the social sciences that will help us understand the situation of patients in more depth. I didn't appreciate what that was teaching. Then I went, I got into Mayo Clinic to learn to be an internist, was chief resident, which exposed me to a lot of teaching opportunities, and then went through the endocrine fellowship. And then I spent 2 years in Canada on a Mayo Foundation scholarship, learning about research and evidence-based medicine with Gordon Guyatt, who is the person that came up with that term of evidence-based medicine. So that's sort of my trajectory, and it's in living through that all of a sudden certain contrasts begin to appear, and then you start to realize certain associations, certain connections that you wouldn't have made if you had just stayed in one of those places. And so, and again, in prospect, you cannot say that you have a 5-year plan to come up with a revolution. This is, you're going through this and recognizing that there are some things that are just not right. And then it takes you a long time and a lot of conversations with smarter people and a lot of interaction with folks to figure out an articulation of that. And then once all that is in front of you, you have to make one decision, which is this something you carry further, or do you go back to the safe? And we are in the carry further phase of that.
Great. Do you think your medical school education planted a seed, or do you think it was really something you had moved aside and it wasn't until you confronted particular situations that you really started to see what was problematic about healthcare?
Yeah, I think my teachers were intentional in setting that up. I think as a student, I did not realize the effect that was having in shaping the way I was seeing the world. For instance, here, I've now been to multiple medical schools in which they have specific programs where you go out and do medical mission type of work, oftentimes very far away from your backyard where you have huge problems. Let's just go to Honduras or some other place that's fancier, right? But no, this was very integrated. This was just part of the whole thing. And it never felt as it was part of the same thing. It felt like, why are we not doing more about the biology of things, of patients? Why are we focusing so much on the biographical elements of their reality? Did not get it when I was going through it.
So in your book, Why We Revolt, the part one, the chapters are organized in a way I thought quite interesting. There's a chapter on cruelty, blur, greed, and burden. Can you describe or summarize what you were trying to achieve there and the kinds of problems you thought you were addressing? And
yeah, maybe you're going to get a pattern here that I'm actually a lot less deliberate than one could figure it out. But these chapters were written, so I'll tell you a little bit about you've jumped a little bit towards the book, and I think that the book is not, the book is a result. I think the book is an outcome of an exploration that over the first 15 years or so of my professional activity, so after finished training, a professional activity, begin to recognize that some things that we wanted to do, mostly focus on advancing patient-centered care, were very resistant to uncovering methods that were proven effective to make clinicians more effective in responding to the needs of this patient. And yet, we will find in that healthcare systems were uninterested, unattracted to it, or when they tried, there was always a reason related to either the way healthcare is funded, the time available, some reason to not really get into it or to implement it. And the recognition that that the fundamental reason why these evidence-based interventions were not being picked up and enthusiastically used in healthcare, in part was because the conditions for care were not present. So when care was happening in healthcare, or happens in healthcare, it's when individual people go out of their way to make a deep human connection with the patient, rather than this is kind of our default setting. It's not our default. Our default setting is that we process people, and that processing of people is often without paying attention to, without noticing the person in high definition in all their situation, in both their biology and their biography. And it is usually not in constructing or co-creating with them a plan of care that makes sense to them. It's more about, processing people and making use of some of the technologies that we have that identify what is best care for people like this to stand instead of caring for this person. And so, yeah, so if the conditions for care are not there, you can do all the innovations in patient-centered care that you would want. And our research group, has produced several important ones over the years. But then the impact, the translation into practice is against, the current. It's not with the current. So what is the current then of healthcare? And is this industrialization of clinical care. And so the book really is a way of saying, wow, what are these pathologies of care that the industrialization of healthcare is causing? And so one is the patient as a blurry, we don't get to understand Mrs. Jones, but certainly we get the illusion that if we read Mrs. Jones' chart, we know Mrs. Jones. We get the illusion that, oh, it's a patient with diabetes. Oh yeah, we know what to do with patients with diabetes, so let's follow the guidelines, without thoughtfully thinking about Mrs. Jones' specific circumstances. So Mrs. Jones stays like a blurry object that we really can't fully account for or understand. We don't notice very well her situation. So then the treatments with which we respond to Mrs. Jones' situation are generic. And oftentimes when Mrs. Jones accumulates multiple chronic conditions, they pile one on top of the other, so they become very burdensome. And then our healthcare system and our payment system introduce additional burden because we don't have the courage to ration care explicitly. So we ration through administrative barriers and through hoops that people have to jump and so forth. And so as a result, Mrs. Jones spends a lot of time running medical errands. Overcoming limitations in our ability to communicate, bridging gaps between different clinicians who don't have integrated care strategies in place. I mean, at times, the only person that knows what's going on with their care, whether they're at home in chronic care or in the ICU, where it's oftentimes the family at the bedside is the only one that knows what the plan is, because the different consultants come in and they don't talk to each other, or they have the illusion of communication through the medical record. So then the care is generic and burdensome to the patient. And underlying all that is the fundamental pressure of efficiency or value, if you want. That's kind of the new thing. And so this idea that we have to process with efficiency because we have these precious resources and all these access demands. And so we just have to meet the two with speed, with hurry. And in that hurried environment, we don't get to notice who this patient is, what is their situation in high definition. We don't get to respond by co-creating plans of care that make sense to them. And as a result, we end up with generic, burdensome care. And oftentimes along the way, when somebody does need us to stop, to listen, to take to heart what's going on and express not just our clinical acumen, but also make ourselves emotionally available and vulnerable, and enact our compassion. When we need to do that and we fail to do that, then we are fundamentally being cruel. Not in the sense of causing deliberate harm, but in the same sense as the opposite of love is not hate, but indifference.
So it seems in some ways, what you're critiquing is a structure of medicine. Is this peculiarly American, or is this something that you see in lots and lots of places?
Well, so remember, I only could speak of what I experienced, right? So I experienced the Peruvian healthcare system in a particular situation. I grew up as a physician in training during Peru's hyperinflation crisis, which made everybody very poor and the country very poor, but also terrorism, which basically destroyed the infrastructure for care. And so it was kind of a war zone in which we were, surviving and taking care of patients. So I saw that, and there was a lot of not just poverty, but, very unprofessional management of healthcare services, waste, corruption, in addition to, again, lack of resources in general. And then I come to the United States, and I appreciate that certain aspects of care, like the ones I just described, were being reproduced in an environment that had all the resources, professional management, rich, and all these other things. So, how is it that is the case? And then I don't know if I get the order right, but then the book comes out, the first edition comes out, and I start seeing a lot of sales going on in countries that have public funding of their system. So Australia, Canada, the UK, Spain. The first translation of the book was in Italy. So why is this applicable there? If I had imagined that the fundamental problem of healthcare in the United States was the profit, the greedy motive that was extracting resources from the point of care to be take-home pay for those who found business in the healthcare industry. And in Peru, what was extracting resources from care was all that corruption and poverty and poor management and all that. What's happening in those countries like Canada, Australia, the UK, Spain, Italy, and what's happening there is there's been a trend over the last few decades of austerity policies that have been investing decreasing amounts of resources at the point of care. So when you look at it from a global perspective, what you basically see is a final common pathway. These might be the endocrinologist in me coming through with some mechanistic thing, but it's almost like a final common pathway in that if you extract resources from care, what you end up having is this accelerated processing of patients in which the patients are a blur, the treatments are generic and burdensome, and cruelty, incidental cruelty is common, and care becomes an accident, a happy accident of the system. And so, and I think in those other countries, they appreciated that, but they also saw that the solution was not to go to a system in which you have private funding or private funding of healthcare, because that's where the stories were coming from, both in Peru, which is a mixed system, and in the United States, which is also a mixed system, in which we have publicly funded systems like the VA and privately funded systems like everything else.
So it seems that in both Peru and the United States, the business of medicine was problematic, and for very different reasons. And that was creating challenges for care. Are there other sort of things happening that are exacerbating the situation? So at one point, I heard you talk about sort of the reliance on evidence-based medicine in another interview, and that relationship to data. Can you talk a little bit about the kind of science of medicine and how that might be an exacerbating factor as well?
Yeah, so I am a big proponent of evidence-based medicine, because I recognize that the evidence-based part is an adjective to medicine. So the fundamental thing that's going on is medicine, is medical care, is caring for and about a patient. And the evidence base is modifying that act. And the modification is that instead of using your imagination and your creative juices and your alchemy to turn somebody that's ill into somebody that's healthy, you're using medical science, the best understanding not only of mechanism, but more importantly of them, of using tests and treatments that have been shown in formal clinical studies to do more good than harm. And so you draw from the, you don't have the evidence tell you what to do. That will be evidence tyranny. It would not be evidence-based medicine. You would go to that body of evidence, relevant body of evidence, draw from it, some ideas about how might we proceed in responding to this particular patient situation, as you would draw from the patient's own experience. So if I take care of a patient with chronic condition, and they know very well what are the kinds of things that have worked in the past and the kinds of things that haven't. And I think ignoring that is it's at least wasteful, right? If not disrespectful. So you could you draw from the evidence, you draw from the patient's experience. And then there might be more than one way forward. And so how do you sort that out? Well, then you have to figure out what is most consistent with this patient's priorities and goals, and what is most sensible in terms of what they can do or not, given their context and situation and circumstances, what's practically feasible. And so that practice, of course, connects very quickly with shared decision-making as a method of care in which you create a conversation, and that conversation becomes your sort of where you prepare the soup, where you put all these ingredients, and out comes a plan of care that makes sense. It connects with this idea of minimally disruptive medicine, which is the notion of pursuing patient goals while having a whole healthcare, the smallest possible healthcare footprint on people's lives. So reducing the healthcare footprint becomes a goal of how you do things, so that you don't spend all of people's time, energy, and attention becoming a patient or being a patient, but rather you free up those resources so they can live their lives. Or at least maybe less arrogantly put, you don't waste those, you don't assume those resources are for healthcare. You respect them deeply so that they stay available for people to live their lives. Now, today, there are some people that look at evidence-based medicine quite differently. And that is, we have evidence that A is better than B. So we make sure that everybody with this diagnosis gets A. Well, okay. And one can see in a situation where you cannot get to meet each patient, for instance, a situation of a very diminished healthcare system with very few resources and low, very untrained or poorly trained professionals, where a system based on a series of heuristics, rules of thumb, if this, then that, you could potentially do quite a lot of good. Think about, for instance, all the ivermectin that was used in Peru to treat COVID. All of that could have been taken offline, and the resources, energy, attention, and hope that was spent on ivermectin could have been spent on making sure people stayed at home, protecting themselves, or had better ventilation in their workplace, or all these things that we did, particularly to working class folks, by exposing them prematurely to disease that end their lives or the lives of their families. So you can do a lot with that protocolized, evidence-based population health. There's tons of terms that you can use where you do this generic response to everybody that is susceptible to that response. But what's your excuse here? You spend 17% or 20% of GDP on healthcare, and you have to act that way? Why? Right? I can imagine that when there's no talent, but think about all these medical schools that are incredibly hard to get into, that charge an arm and a leg for the education they give, that put their brightest teachers in front of these incredibly bright young people to teach them to follow the guidelines. When I get the people rotating through the endocrine clinic and I'm with them, it's very frequent that I get as an answer, what would you do with this patient? Well, the guidelines indicate that we should do. Yeah, you should be replaced by an AI machine, buddy. That's in your future. Well done, right? When medicine is supposed to be hard, it's not supposed to be a matching job of, this patient goes with this guideline, that's a recommendation. If that was the case, then how do you explain spending 4 years in medical school and accruing that debt? That's crazy.
So as you describe sort of your critique and then the alternative, I think, someone in their mid-50s, I have never been to a doctor that is as your ideal describes, ever. Right? This notion of co-creation right? It seems antithetical to what it means to go to see a doctor, right? And so, right, and again, just turning to your book, there were sections that I just loved, and there were two chapters, one on solidarity and one on love. And could you just, the love chapter, you have this line that a patient has, sort of after 10 years, had never said that they loved you, right? Sort of, and what that relationship is. Could you talk a little bit about what medicine that considers solidarity and love at the center, and why that's so important?
Yeah, one beautiful experience of writing. I'm not a writer, right? I mean, this book had to come out. It was an urgency. It had to come out. And in fact, I actually asked for permission to write, to my institution, to write a book. That's the process you follow at Mayo. And the book I initially proposed was actually something that was going to summarize our research. And I was writing our summary of our research, and it was so boring. I couldn't write it, let alone expect anybody to read this. But then when I let myself, and so I started reading a lot of books about writing, and so I'll do this or that. So I started doing those exercises. The book that tried to come out was the book that eventually became We Revolt. So it had to come out. Well, as I was, writing the chapter, certain things began to become clear. So one of the things is that some people imagine that you write what you have clear in your mind. No, you're right to clarify, you're right to discover, you're right to uncover relationships and notions that perhaps remained unclear in your head until you had to write them. And then when you start writing them, you start seeing them. Love was one of those things. When you read, or when you try to discover what love is about, love is first is relationship. It is openness, it's vulnerability. And I'm not talking about romantic love. I'm not talking about erotic love. I'm talking about maybe filial love, maybe the love of parents and children, maybe the love of siblings, maybe the love of longstanding friendship. The kind of situation that where a sit down with complete openness and a conversation about something that is almost secret, difficult, profound is possible. That sort of safe space, where the fact that we're having a transactional relationship where you're paying for my services and I'm giving you my time is no longer at stake. What is at stake is this connection that we have, which is in fact the source of of resilience for your journey as a patient. So as a chronic patient, the most likely outcome is disappointment. The most likely outcome is deterioration. The most likely outcome eventually is death. And so the challenge then is, where does the patient get their resilience? Well, it is from their relationships of love that they have with their family, with their loved ones. And I also assume that it is also with their clinician. And so, for instance, when that interactions are transactional and there is a disappointment, one common behavior of the patient is to do doctor shopping and go and find some other clinician. Well, how distressing is it to not only lose whatever, gamble you just made on a particular treatment, but also lose the relationship that led to that treatment, and have to reconnect, and in that situation of defeat or disappointment, have to reconnect with someone who you have to explain your whole story again. And so rather it will be like when my kids grew up, and my hope is that they come home, and that home will be a place of infinite love, infinite understanding, forgiveness, and the place where they could recover, reconfigure, re-engage and try again. And I see that in the best of the relationships that I have. Is not everyone, but in the best of the relationships we have, that sort of relationship emerge, and emerges first in casual language before it's fully experienced. So you start hearing patients say, "Oh, I love my doctor." They don't really love their doctor, but they sort of love their doctor. And you hear clinicians talking about, "Oh, I'm having Mrs. Jones is kind of, oh, I love Mrs. Jones. I'll see." And again, it comes on first in casual language like that. But then when Mrs. Jones has a disappointment, is your disappointment. And you often find yourself having discussions where you are disclosing some of your stuff. You are making yourself vulnerable because otherwise it feels very asymmetric. And so you're throwing lines at each other. You bring in the boats closer together. You're allowing each other to board each other's boat. That is a position of vulnerability that many professionals do not allow themselves to have, and some people recommend against. Um, there's a dimension of human experience that they're missing if they are keeping those both separate. And sometimes you need the separation to make difficult decisions and to have the emotional distance to do so. But I think that that is overplayed. I think that the ability to be in it together with your patient, even though you're not suffering personal negative consequences of the bad decisions or the bad luck that good decisions that lead to, is a minimum of solidarity that you can have with those who are suffering around you. And it's a place from which you can draw a tremendous amount of meaning, tremendous amount of energy. You can be taken advantage of. You can be hurt. That's what vulnerability, you're vulnerable to something, to some harm, right? And that's what vulnerability brings to it. And that's why it's important that healthcare organizations, groups of clinicians have mechanisms to support each other when that happens, that you have compassion rounds, that you have, opportunities for casual interaction and get together so that you can take care of the people that take care of those patients. That's why that is important. But I don't think burnout of the one that is affecting our workforce right now comes from too much engagement. I think it comes from the emptiness of processing patients and not having the opportunity to really care for, about, and with them.
So can we talk a little bit, sort of take that notion and back it up into the education of future doctors and healthcare workers, starting with sort of the pre-health work that students at a place like Notre Dame or Duke would have, right? So at a place like Duke, 40% of the students imagine that they're going to go on and become a doctor. About 25% eventually apply to medical school. So a huge proportion of the population. But for many of them, it's a non-decision that gets made in a non-conscious moment. So, right, a conversation with grandma at age 3, what do you want to be when you grow up? A doctor sounds like a good thing. And that gets carried forward in a student who's very good in high school, good at science, gets to college and someone says, what are you going to do? And they say, I'm going to be a doctor because it sounds good. And just keep playing that game and moving forward. There's never really a deliberacy oftentimes to that decision. How should we be thinking about the kind of pre-professional education of future healthcare workers, given this non-decision? And are there things we can be doing even with undergraduate populations to get them thinking differently about what it means to work in health care and to put care at the center of that?
You will think that, so I think medicine, nursing, social work, psychology, occupational therapy, physical therapy, the helping professions, I see them all as similar. I know we have massive hierarchies across those professions, in part because of massive differences in income that can be realized in those professions. So there's some distortions there about the relative importance of people on the basis of how much we reward different people, and this of course is outside of healthcare, just look at teacher salaries and so forth. So to commit yourself and professionally to the help of others is I find that's magical. It is an incredible way of spending one's life. That's not for everybody. Some people find that the way they want to make a difference in other people's lives is by creating jobs and forming companies and producing the products and services that transform other people's lives, and do so by consumption of those services or by providing employment to people and that's great. And there are other people that, again, everybody has a different sort of, calling will be a perhaps too big of a word, but that's might be a word. So why choose to have a career in care? I think today is countercultural. I think today, if you actually choose to care for other people, it's countercultural. I think we're right now in a cultural situation in which what is being exalted, rewarded, front page of the magazines is the opposite of caring, right? So it remains to be the success of those who are developing massive personal profits at the expense of the planet, at the expense of other people. So caring, which somebody has defined as making the world a place where you can live a little better. So that could be self-care. You can make yourself a world in which you can live better. You can care about your environment, your social environment, your community, and make your neighborhood a little easier a better place to live in, where you can care about your environment and make our planet, our material world, a better place to live in. So care is being environmentally green. It is about economic and social solidarity. It's about opening up your house, your actual house, or your nation's house, to the plight of the immigrant and the refugee. And Paul Farmer just recently died, and he pointed out that this idea that different lives are worth different is at the heart of everything that's wrong in the world. Well, yeah, and so care is a position in life that recognizes our responsibility to others, that comes with the fact that we also expect to be cared for if we ever need it. And it's a responsibility that shouldn't be a whim. That's the other thing, is that this is something that is not fair, is not democratically, the responsibility for care is not democratically distributed, continues to be fundamentally given to women, particularly immigrant poor women who come in to the northern hemisphere, to do the care jobs that women in the northern hemisphere are leaving behind to join the productive economy, without recognizing that there is this reproductive economy that actually makes our worlds a little better to live in. And that shouldn't be just the responsibility of women, but it should be the responsibility of all, since we all expect it for ourselves. So that world, if we had a world in which everybody cared for and about each other, that cared with each other for the environment and so forth, spending your professional time doing the same thing, oh my gosh, you'll be all the same. But in the moment, it's revolutionary, it's countercultural to see your fellow human as someone who is a member of your family, and one of your kin, is that kind care that I talk about, the ability to respond to them, not in the way you would like to respond to yourself, but the way they would like to, the fact that you're curious about what matters to them. Oh my God, right? And then that then you can use science, and both social and biological, to respond to the biological and biographical challenges that this person is going through. And you can use technology and technique, if you're, for instance, surgeon or intellect, to figure that out and to advance the problem. But that's not what the kids hear. What the kids hear is that, I need to fill this form. I need to complete this procedure. I need to get this documented in the chart, because I have to spend time, 40% of my encounter with you, documenting in the chart the care I'm giving you, rather than spending the time caring for you. That's what they see. So maybe I have better uses of my time, right? I mean, that just seems incredibly, at least, boring and defeating and grinding and so, yes, not only are people not joining, but people are dropping out. And my colleague Colleen West has estimated that about one full medical school class leaves medical practice every year because of burnout. So yeah, you can put a bunch of kids on the front end, but if you're dropping a class every year, you have a negative deficit. So it's not only countercultural society-wide, but it's unfortunately countercultural within healthcare. And that's why I think it's fundamental that we look at the structure of healthcare and we seek a fundamental change to the structure. We got to move away from industrial healthcare. We got to move towards careful and kind care, not only because it's what we need for financial sustainability of the system so that we can actually care for people and do it well, but because we need it for human sustainability. We have these incredible hearts joining in to care for people, and we are grinding them until they're bones, and that's unfair. And so yeah, the kids are all right, and they're making rational choices to stay away from this thing. It's not a good idea. It could be great though.
I think it's interesting. You talked about it's countercultural to have a career in care, and it's funny. I never would have thought of medicine as actually a career in care. Like in a right, a career in science, a career in technique, a career in medicine. Care seems to be way down in many ways. And I think what you're describing is a kind of reprioritization that is counter to the industrial nature of medical care that puts care first.
We have in the Patient Revolution, we have a fellowship, right? So we have the Patient Revolution Fellows. And with a group of them, we decided to write an article for leaders in healthcare. So if leaders in healthcare are in a position to change this, what do they need to do? And the best line in the whole article, it's silly, right? Because it basically says, is to commit the healthcare organization to care as its primary goal. Yeah. What other goal should it have, right? I mean, it's like, but you have to say it, and it's silly, right? I mean, you have all. If you look at the mission statements for most healthcare organizations, they're all kind of saying that. But really, is that is when you make decisions, is that the top priority that you're advancing, really? And the answer is, I think, is evident to all of us. In fact, you said I couldn't think of it. And many people that are in technologies or developing the innovations in healthcare see medicine as a practice related to information. They think that it is an information and data practice. And so if we just knew enough, if we just did that other test, if we just were to give you the information so that you can have it in the palm of your hand, if you were to just have that watch that looks at every parameter and all your behavior were monitored and integrated with the latest machine learning and AI thing, and we can give you that back and we can change your behavior, you'll be healthier. No, that you're missing the point. And just because you're an information scientist, or just because you're an information entrepreneur, just because those are your tools of the trade, doesn't mean that care requires that. It's the typical consulting a trick, right? You take a problem that is complicated, wicked even, and then you reformulate it into a problem you can solve, and then you offer the solution to the problem, but you're not solving a problem that they don't have. And I think that's what we're hearing right now. I think most organizations in healthcare, the ones that are visionary, are investing quite a bit of resources in becoming present and active in an information-based approach. And they're investing a lot in platforms, and investing a lot of in computational capacity to do all these management of information. Absolutely great tools. We draw from them the necessary ones that will help care for this person. But where is a similar investment in care? It's very hard to see. It's completely taken for granted. And it's just assumed that if you give people the right tools, they will figure out a way of caring. Next patient.
And so how do you get people to care? Yeah.
You don't. No, you don't care. No, you don't. Right? You create the conditions for care to emerge. One of the contributions of having more women in science has been the recognition that the response to stress is not simply to fight or flight. There is a response of tend and befriend. There is a response that is to care for and about each other. We saw it at the beginning of the pandemic. people that could, medical students in Minneapolis set up a daycare for the nurses that had kids and couldn't come back home safely because they would infect their family, for free. Mutual aid exploded in multiple places to help folks in need. Those who couldn't do something hands-on, they start needing, face masks, and everybody did something for somebody with no expectation of recognition of reimbursement. What was that? So Rebecca Solnit, in this book, Building Paradise Through Hell, has this idea that when we are faced with an emergency, with something that is a shock to the system, it's like when you unplug the computer and you plug it back in, what comes on is the firmware, is what's built into the computer. What comes on in humans is the need to care for and about each other. That is our default software. The software that then kicks in after we are operating for a while is different. It's one that begins to focus the attention on ourselves and our self-interest. And that's a different software, perhaps more culturally mediated than the inclinations and the impulses that we have under stress. But we now have a full generation of people that have witnessed our ability to take care of each other. Right? So when somebody like me says, oh, we should be able to take care of each other, people go like, you're a poet. You're a poet. No, we've all seen it. We've all seen it. I mean, we've all seen it in our own neighborhoods. We've seen it. We've seen people that we never expected. Everybody gave of each other. And of course, we have to recognize the health professionals, the caregivers who went in without adequate protection to care for. I mean, we've lost so many folks, and I think we always have to recognize and remember their sacrifice, which was the biggest manifestation. I couldn't have predicted that in the book. The biggest manifestation of cruelty in healthcare, that we were cruel to our clinicians by not protecting them with adequate personal protective equipment from day one. Our efficiencies meant that we had no stock to protect them. I mean, think about that. And so the cruelty was made evident at the beginning of the pandemic, not on the way people responded to each other, on the way healthcare responded to its own professionals, and in the way healthcare responded to patients by preventing loved ones to accompany them inside the hospital, even if they were willing to take on the risk of being with them in the hospital. So the fact that we isolated people in nursing homes, isolated people in the hospital, and then invited the healthcare professionals in without adequate protection demonstrates the depth of cruelty. So how do you make people care? You create the conditions for that firmware, for that basic human response, which is a response of empathy, of compassion, of caring for and about each other. I'm not Pollyanna. I know that we are selfish sometimes, but I also see those videos where the river comes rushing and there's one guy stuck in the car, cannot get out, he's about to drown. And then there's this chain of complete strangers, the whole chain of people there never met each other before, and they're holding on to each other until the last guy can pull the person out of the car. Why are we doing that? Why are we doing that? Are we doing that because we are humans, because care is part of who we are? And so we just have to, clear up the air, create the conditions for that to emerge, and to emerge in a professional environment with standards, with quality, with back office processes that are not wasteful. So there's more resources so that we can take the time that we need, have unhurried conversations and care for folks. And then the other side of that is, if we just make this a movement within healthcare alone, it won't succeed, because we are at the same time delegating increasing amounts of care to professionals. So I think grandmothers are no longer allowed to give advice about how to take care of babies, because of, oh, the kid is, you need to take him to the doctor. If you go too late, it could be too late. And so we have all this anxiety, and we have to recognize that not all problems require healthcare professionals for response, that there are assets in our community that will allow us to deal with problems, particularly problems related to loneliness, mental health, and even physical health, where assistance might be available in the community without having to go to the clinic or the hospital. So we need to develop care in the community to promote health, to recover from some minor issues with the assets of the community, and reduce the size of professional healthcare to only the situations where, in fact, you do need a health professional to help out. And in those situations, I think if we are able to balance that right, which we don't have that balance right at the moment, then the possibility to have an unhurried conversation with the clinician in which the clinician can appreciate and notice your situation in high definition and co-create with you a response that makes intellectual, emotional, and practical sense becomes increasingly feasible. And then through a nice feedback loop, being part of that, having the privilege of being at that bedside will become an incredibly attractive possibility as a career for any young person who, wants to embody care.
That's great. So the questions are queuing up fast and furious, so I'm gonna toss you a few. Your beautiful description of seeing patients in their concrete uniqueness instead of seeing them as abstractions reminds me of the American poet and physician William Carlos Williams. He described writing poetry and practicing medicine as similar in their careful attention to concrete details. Where do you get the resources that help you see your patients in high definition, as you say, rather than blurrily? Have those been medical and scientific or other resources? So
that's a great question. So I think, well, I don't, if I was able to do what I'm describing to do every day, first of all, I would probably have a less of a sense of urgency about this because I'll be comfortable, I'll be happy. But I get to do it sometimes. And on a good day, that's the expression I use in the book, on a good day, when this happens, it's actually quite interesting. It might be a no-show. A patient doesn't show up, and all of a sudden I have a little bit more time. But it also might be that the patient is disposed to open up. It's particularly quiet in the room. I personally am not in a hurry. I am emotionally quiet in the room. And we have, as humans, ways of noticing these things that are not verbalized, that are not technical. I'm not teaching a medical student, no, be quiet. No, it's you find yourself in the moment and you find yourself there. And then you start hearing things. And of course, I have now a few years of experience taking care of patients, and you start hearing things differently. So when somebody tells you that they live in a small town and they're having all these medical problems, and it's a woman, one of the things that you're hearing is, this woman is expected to care for herself and for a bunch of other people, and she is sick. So I wonder how she's negotiating those other care functions. The trainee hasn't heard that, because it's almost like when you watch those Sherlock Holmes movies, like there's mud in your shoe and you must have crossed the railway. And like, you guys, you don't know that, right? But you start hearing those things, and you start getting a sense of what's going on. One of the things that makes that hard is that there's an increasing socioeconomic distance between physicians and their patients, such that we have very few experiences in common. We don't live in the same neighborhoods. We don't live in the same places. We don't go through the same challenges. We don't shop in the same locations and so forth. So that impairs, and we don't do home visits. So that impairs our ability to tell. So it's very hard. How do you notice the small things out of context in an office when people are trying to often hide them because they're embarrassing or they're difficult? It's incredibly hard. And we make it harder by the way we set up our interactions. Telemedicine has been interesting. You see behind me, you see my life, my home, or at least some aspect of it. You start seeing some people's homes behind them and maybe getting some clues. But the fact that we find home visits incredibly inefficient, I think, is a tell.
So we probably have time for just one more. So
if the questions are easier, I can answer faster. It's like...
So here's one about coursework or educational experiences that could be added to health professions education curricula to help students tune into the centrality of care, regardless of their chosen profession: doctors, nurses, future CEOs of Healthcare America, and so on. What could we do differently
Yeah. Well, there's a ton of innovation going on in medical schools these days. There are people that are taking kids to museums to appreciate art and other things, or medical humanities courses taken seriously, where you can, since the kids are going to be seeing patients and they have not lived lives, because that's the other thing, is that we're recruiting a lot of privileged people into healthcare, particularly into medicine, and so the exposure to suffering is exceedingly limited. I mean, I suppose if you ask kids, how many people have you seen die before you came in here? How many people have you cared for that have been sick and ill and suffering? The experience is rare. Not in their personal statements, I'm talking about in their actual lives. It's extremely rare. So those are great. I think you can live vicariously through literature and all this other stuff. I think I will take a step back and ask a fundamental choice for teachers today, which is, when you train a kid that's coming in to become a health professional, when you train them today, do you train them to work well within industrialized healthcare? Or do you train them to be a change agent, to try to move industrial healthcare towards a system capable of careful and kind care? I can imagine the answers will be, if I train the kid to be a change agent, I'm training them to be frustrated. I'm training them to be difficult. I'm training them to not be successful. And my job is to make them successful. So I train them to work very well in an environment that rewards efficiency and throughput and fast and furious work. I think that's the fundamental ethical dilemma for teachers of students today, which is, what future do you prepare these kids for? And of course, my dream is that you develop several generations of deeply uncomfortable professionals that will create the conditions, not just for care, but will create the conditions that will create the conditions for care. I think most medical schools are not taking that route. And I think that might be the fundamental question I think we should debate.
Do you think you can address that question without sort of replacing the industrial medical complex, right? Is that required, or could you overwhelm the system with people who put care at the center?
Yeah, I think it's a very dangerous proposition to overwhelm the system. It's almost like a denial of service attack in the internet, right? So when I go along with a patient, the next patient is now waiting too long. The next patient is now running out of time, has to pick up the kids, so might actually have to skip the appointment, which means that they wasted the whole afternoon, and that my desk colleague, who has to leave when the last patient leaves, is no longer able to see their kids' soccer game. Right? So these personal heroics, where I take all the time that I need, actually are at the expense of other patients and other professionals. That is not a route. I am an impractical person. I see my job as to being profoundly impractical. That's why I'm not the CEO of anything. Right? If I was a practical person, I'd be a problem solver and a solution-driven individual, right? And so then I'll be in a position of authority and leadership. I am not, and because I'm unreasonable about this, I actually do not see us improving the system all the way to making it create the conditions for care. That could be a lack of imagination on my part. So it might be that there's somebody here that thinks, oh no, we can do that, and I have a way of doing it. Join our fellowship, take us there. Prove me wrong.
Great. Well, certainly, I think this conversation could have gone on for 3 hours, but I'm going to have to stop it there. And thank you so much. This was just a wonderful way to spend the lunch hour. So thank you so much. And for folks who joined us, thank you again. And please join us on March 21st to discuss ethics education for engineers with Rosalind Byrne. And thank you again. This was just delightful.
Thank you, Susanna. Pleasure talking with you. And I wish everyone to be safe and to thrive.
Wonderful. Thank you.